Hello, I am Dr. Tayoto Sano, and I will be talking about the pediatric obstructive sleep apnea. So first, we're going to talk about sleep disordered breathing. This is a spectrum of conditions, abnormal breathing affecting about 12% of children. On the lower end of the spectrum is primary snoring, which is just snoring without any obstruction. The child will frequently arouse from sleep, and there may be some gas exchange abnormalities. Following that is upper airway resistance syndrome. There's snoring, there's labored breathing, and disrupted sleep. So the child will wake up and the sleep is fragmented, but there are no discrete obstructive apneas or hypopneas. Obstructive hypoventilation syndrome, and that is persistent partial upper airway obstruction associated with gas exchange abnormalities rather than discrete cyclic apneas. I'm going to have you please just review the terminologies, apnea, hypopnea, just so that we have an understanding of these words. So what is obstructive sleep apnea? This is a potentially serious sleep disorder. It causes breathing to repeatedly stop and start during sleep. And it happens when the throat muscles intermittently relax, fall in, block the airway during sleep. And it may lower the oxygen level in the blood, and this decreased oxygen is sensed by the brain by chemoreceptors. The patient wakes up and starts to breathe again, and the cycle just goes on over and over throughout the night. Because of that, the patient is not able to have a really good quality relaxing sleep because they keep waking up several times. I mean, their sleep is fragmented. What about pediatric obstructive sleep apnea? Pretty much the same OSA like we've discussed, but this happens in children. And the prevalence of OSA in children is about 1.124%. It's more prevalent in African American and Asian kids. There is an equal distribution for males and females. Peak age for OSA is about age 2 to 8. And it's reasonable because at that age, the tonsils and adenoids are at their largest relative to the overall airway size. Also, larger kids, the kids that are overweight or obese, they tend to, because there are more kids that are overweight and obese, so this changes the age distribution such that kids older than 8, if they were larger, would tend to have OSA. About a third of all kids that snore have OSA. So it's important when you are doing an oral evaluation, if you notice that the tonsils or adenoids are on the larger size, it's a good idea to ask the parent, does this child snore at night? And we will talk about how to evaluate tonsil size later on down the course of this lecture. What are the symptoms of OSA? So there is excessive daytime sleepiness. And this is because kids with sleep fragmentation, they're not sleeping well at night. So during the day, they're more likely to be very sleepy. These children would have loud snoring 3 or more nights per week. And there should be episodes of breathing cessation that another person witnesses. So if a parent comes to you and says, "Oh, I think my kid has OSA," they need to be able to, tell you that they have seen this kid sleeping and suddenly wake up because they stop breathing. And that brings us to the next one, which is abrupt awakenings accompanied by shortness of breath. The child wakes up with a dry mouth or a sore throat, and this is because their mouths are generally left open, so they're mouth breathing. And this is just your body trying to compensate. You're sleeping at night, there's not enough air coming in through your nose, or the air is coming in, but it's not going through the pharynx into the lungs. For that reason, your mouth opens to try to get more air in. Also, so this will make them wake up with a dry mouth or a sore throat because their mouths are dry now. Also, because of that, they're more likely to have cavities because their mouths are drying out, and they may also have what we call a long face because they're leaving their mouths open. So their jaw line, when you measure the angle, not the angle, the border of the mandible to the cranial base, they're usually called what we call hyperdivergent because they're constantly leaving their mouths open. They wake up with a headache and they may have attention problems. This is because they're not sleeping well at night. And there is usually behavior problems like increased activity, aggression, poor concentration, and irritability. And young children are more likely to express that increased activity and aggression um, rather than act or complain to be sleepy. So they're sleepy, but they're fighting that sleep. So for that reason, they're all over the place, super aggressive, super irritable. They may also have difficulty waking up in the morning despite having what appears to be an adequate time in bed. So mom is concerned, well, you've been in bed for about 8 hours, and why are you finding it difficult to wake up? So that's another question to ask the parent. Do you find it difficult to wake this kid up? Does the kid really struggle to get up in the morning? And usually they may have increased sweating. And talking about mouth breathing again, children with upper airway obstruction that mouth breathe, besides the increased risk of caries, they also may have halitosis, nasal congestion, rhinorrhea, and they may have a hyponasal voice. And this is because their tonsils are big, pretty much. So they're mouth breathing not only when they're sleeping, but throughout the day. So the importance of diagnosing OSA in children cannot be underestimated. And recent studies show that impaired school performance for teenagers that are loud snorers, as well as an association between behavioral problems and OSA. So it is very important to consider the diagnosis of OSA in a snoring child who otherwise meets the criteria for ADHD. There's talk these days about ADHD probably being a symptom of OSA, meaning some kids that are diagnosed as ADHD, if they were treated for OSA, the ADHD sometimes just disappears. So to remember the behavioral complications that a kid with OSA would display, mnemonic is APRO. So A for aggression, P poor school performance, R restlessness, I irritable or hyperactivity, and L lacks attention. What are the signs of untreated sleep apnea? Enuresis, also known as bedwetting. Poor performance in school due to misdiagnosed ADHD, like we mentioned prior, aggressive behavior, developmental delay, impaired growth, and this possible impairment is probably due to problems with growth hormone, and the end organs are not responding well to the growth hormone. increased caloric effort with the respiration, so they're really working hard to breathe. So they are pretty much working harder than they're probably eating. So for that reason, they're not growing as well. They also have difficulty with eating, so all of that just comes together to play, causing their growth to be impaired. It may also be associated with GERD, which is gastroesophageal reflux disease. Other causes and risk factors includes adenotonsillar hypertrophy, upper airway congestion. Kids with allergies are more likely to have OSA. GERD, like we mentioned. Kids with cleft palate are more likely to have OSA. Craniofacial dysmorphism, like patients with midfacial hypoplasia, like Down syndrome, or children with when the things that cause the sutures to prematurely close, craniosynostosis, they will have mid-facial hypoplasia as well. So those kids are more likely to have OSA, and this is because their mid-face falls back, and for that reason, all of the area in their pharynx is crowded. There's just too many tissues there. That makes it difficult to breathe. Micrognathia, please forgive the typo. It should be micrognathia, not micronothia. So things like Pierre-Robin syndrome, and this refers to when the lower jaw, the mandible, is small. And when that happens, their tongue falls back. Tongue falling back also crowds the pharynx, more likely to have OSA. Cranial base malformation, like achondroplasia, pretty much is the same pathogenesis as midfacial hypoplasia. The midface is small, things are crowded in the back there, they're more likely to have OSA. Neuromuscular disorders like hypotonia, seen in Down syndrome, or muscular dystrophy, or spasticity in cerebral palsy. How that causes OSA is the neck muscles are not tonic. So they're flaccid, the fall into the pharynx, crowding that area, more likely to have OSA. Other things include overweight and obesity, like we talked about, sickle cell disease, cystic fibrosis, because they're more likely to have nasal polyps. That also makes it difficult to breathe. Chronic lung disease, bronchopulmonary dysplasia, and scoliosis are also cause issues with breathing. Scoliosis will cause an issue because when they're sleeping, they're not able to extend their necks. So they're more likely sleeping with their necks flexed. That also crowds the pharynx and causes a difficulty with breathing. So all of that I explained as regards to the anatomy, the slide will explain even better. The upper airway is a pliant tube with side walls that consist of muscle and other soft tissues. When you're awake, neural input to the muscle groups in the pharynx maintains the muscle tone and airway patency. So when you're awake, all the muscles in the neck are active, they're tonic, and they're keeping your airway open. When you're sleeping, there is an increased resistance to airflow, and this also accompanies muscular relaxation, so everything just is nice and flaccid in that area. You're sleeping, laying back, your tongue falls back. There's just more resistance to air going into your airway. Most people will compensate for these changes, but people with certain anatomic problems will have OSA, or upper airway obstruction, at least when they sleep. So here is a picture, kind of like showing us what the open airway looks like. And I want you to pay attention to this dotted line circle. And you can see, even though this person is laying back, their tongue falls back, but the airway is still able to stay open. the air comes in from the nose, goes down in this light blue arrow into the airway. We're happy, we're breathing, and we're sleeping okay. In OSA, the tongue falls back, air comes in, it's an obstruction right here. So patient opens their mouth reflexively to try to get more air in, not able to get in. And as they try to breathe, they're sleeping. They're trying to breathe. You would hear snoring because the tissues of the soft palate, the tongue, and the pharyngeal wall will vibrate against the air trying to come in. So that's what causes the snoring noise. The primary etiology is either anatomical, like we talked about, or neuromuscular, like we also mentioned. So anatomic considerations are large tonsils, bone malformation, and that would be things like cleft lip. I'm sorry, not cleft lip, cleft palate. Soft tissue infiltration, like storage diseases, like glycogen storage diseases or lysosomal storage diseases. Patients with Hunter-Hurler syndrome, they just have a lot of infiltration from inability to metabolize glycogen or metabolize some proteins. Those metabolites kind of like just get stuck in the tissues because their bodies are not able to process them. All of those infiltrations just back up in the areas of the neck. Not only in the neck, they also have this infiltrations in every soft tissue in their face, all over their bodies. But because it's all over, when it's in the neck area, it will cause resistance to airflow while sleeping. Other physical factors, like we talked about, small mid-face, cranial problems, narrow nasopharynx, so things like the nasal polyps will cause that, a large tongue. Kids with Down syndrome generally have a relative large tongue, muscular hypotonia, and things like muscular dystrophy. Kids with Down syndrome also have muscular hypotonia, obesity, and a small larynx. So here's a picture showing you very large tonsils, and these are what we call kissing tonsils, just because, you know, they're coming close together. And this is a little endoscope, kind of like going down beyond the tonsillar area. And this, I believe, may be a lingual tonsil, just distal to the tongue, way in the back in the pharynx. So how do we classify tonsillar size? So the Brodsky classification will help you evaluate tonsil size. And grade 1 tonsils, actually there is a grade 0. Grade 0, you look in the back, right where my cursor is, in between the fosses, you shouldn't see any tissue. That's a grade 0. Grade 1, you just kind of see it a little bit right here. And what you want to do is you want to draw a line, midline from the incisors all the way down. Just follow my cursor right there. And in between this interior pillar and that midline, when you have your tonsil occupying less than 25% of that space, you have grade 1. Grade 2, a little more beyond the facial pillars, and it will occupy between 25 and 50%. Grade 3 will occupy between 50 and 75%, and grade 4 will occupy greater than 75% of that portion, all the way to 100. It may even cross over to the other side. And this, like I mentioned when we saw the picture, are called kissing tonsils because it looks like they're giving each other a kiss. So the Mallampati score is another simple test that can be a good predictor of OSA. And in anesthesia, the Mallampati score was developed to predict the ease of intubation. The higher the Mallampati score, the more likely a kid would have OSA. Same as for the Brodsky. Tonsils that are Brodsky 3 will probably snore, and patients with Brodsky 4 tonsils are they're highly likely to have ASA. So for the Mallampati score, you have the kid open, stick their tongue out, and sometimes I ask them to say just because some kids will not open really wide for you. And when you look in the back, and you should be able to, if you see the entire soft palate, that's a class 1. If you see the uvula only, that's a class 2. So let's back up a little bit. A class 1, you would see the entire soft palate. You would also see the fossal pillars, so the anterior and posterior faucets. For class 2, the tongue is a little bit more elevated, so it kind of blocks your visualization of the faucets, and that is, you would see the uvula though, so that's a class 2. At class 3, you only see the base of the uvula. In class 4, you cannot even see the soft palate at all. You can only see the hard palate. Usually when you're doing this examination, you can do the Brodsky and Mallampati at the same time. You just have the patient open, stick out their tongue, do your Mallampati and say, then you do your Brodsky. Kids with Down syndrome have a 50 to 100% chance of having OSA. And that is just because of the physical factors, like we already talked about. The narrow nasopharynx, the large tongue, the muscular hypotonia, obesity, small larynx, congenital heart problems, leading to cor pulmonale. So cor pulmonale is right-sided heart failure because of a respiratory problem. So how do we diagnose OSA? Pediatric dentists are in a unique position to identify patients at greatest risk. Patient comes into your office, you see them mouth open, long face, hyperdivergent. You start to think, maybe this kid has OSA. You have the patient in the chair, you ask questions of the parent. Does this child snore at night? Do they have attention problems? Do they have problems getting up in the morning? Are they being diagnosed with ADHD? Then you do your Brodsky Mallampati evaluation. If you see adenotonsillar hypertrophy, if the kid is larger, meaning overweight or obese, then you're starting to think, possible OSA. And you may also administer a questionnaire. It is called the PSQ, the Pediatric Sleep Questionnaire, and this was developed to identify children at risk for OSA. A simple sleep questionnaire that you can have in your office is just to ask these questions. We already talked about them. Snoring, trouble breathing while sleeping. Does the child stop breathing during sleep? And meaning someone has to witness that they did stop breathing and they struggled they were awakened by that, and then they start to breathe quickly, breathe fast, trying to catch their breath. Do they bed wet? Hard to wake up in the morning, headaches in the morning, mouth breathing. Teacher told you that your child appears sleepy or is irritable or aggressive or hyperactive, and does the child fall asleep quickly? Because they're tired, so they just go to bed quickly, but then they wake up multiple times at night. So you have a patient that you're thinking, this is possible. This kid may have OSA. As a dentist, you cannot diagnose OSA, but you can note the possible symptoms and signs and flag it and let the physicians know. In some situations, you're unable to refer to a medical specialist. You may have to refer to their primary care first, and then their PCP will coordinate the referral to the specialist. For the specialists that we can refer to, via the PCP, ENT, the otolaryngologist, a pulmonologist, or sleep medicine physician. And the only way to diagnose OSA is a clinical examination, which, you know, we could do a little bit in our office, and a sleep study. So you have to have a sleep study before you can be diagnosed for OSA. And a positive diagnosis of OSA is likely made by a sleep physician in the presence of signs and symptoms concurrent with at least one predominantly obstructive respiratory event, mixed apnea or hypopnea per hour of sleep, or a pattern of obstructive hypoventilation with hypercapnia for at least 25% of total sleep time during the sleep study. The sleep study, also known as the polysomnography or PSG, because that's a long word. So like what happens in the sleep study is the child comes to the sleep lab. There's tons of monitors attached to the child that would monitor their heartbeat, their pulse, their blood pressure, their CO2 levels, and also monitor their movements. So if this child is like tossing and turning, not able to sleep, and there would also be like a video kind of like watching all the child while sleeping. So treatment of OSA. There are surgical and non-surgical treatment options. And for non-surgical, if there's nasal allergies, you take care of it. You may give CPAP. And what CPAP is it's positive air, kind of pushing air through the nose, through the mouth, to not only go past the obstruction, which may be the tonsils or the soft palate or the large tongue, but it also keeps the nasal and pharyngeal wall patent. So the pressure is so much that if the walls of the neck collapse, it makes it difficult to breathe. This pressure keeps the walls wide open. You can also talk about reducing weight, pediatric dental or ortho intervention, and you can also have them change the sleep hygiene, meaning keep a consistent sleep schedule, get up same time every day, even on weekends and during vacations, set bedtime that's early enough so that they can get at least 7 hours of sleep. Don't go to bed unless they're sleepy, so they should associate bedtime with I'm sleepy. Not a lot of bright lights, because you want to keep the room dim so that it encourages them to fall asleep, and have them stop using their electronic devices at least 30 minutes before bedtime. And the machine up here in the top right is a CPAP machine. So it's just kind of, the mask covers the nose and the mouth. You have elastic straps to keep it well adapted to the face. And this is the little pump that pumps the air at a certain pressure. Surgical treatment. The most common surgical option is adenotonsillectomy. You're removing the large tonsils. You may also have the UPP procedure, the uvulopalatal-pharyngoplasty procedure, and this just opens up the oropharynx by removing tissue in the throat, the uvula, soft palate, or in addition to the tonsils. You may also have ablation, which is either like an electrocautery or some electrosurge, just to shrink the tissues in the soft palate. You can also do distraction osteogenesis, and this is usually for patients that have things like Pierre-Robin syndrome, where they have a small mandible, and distraction osteogenesis just brings that lower jaw forward. Remember, your tongue is attached to the genial tubercle on your lower jaw, so bringing the jaw forward will bring the tongue alongside with it, and that just opens that airway up for the patient. You can also have tracheostomy, but that is honestly way at the end of the spectrum. We've tried everything else and nothing else works. Tracheostomy. So we talked about the dentist, the pediatric dentist or the orthodontist intervening, and there are certain appliances that can be fabricated in a way that the patient will wear it, either permanently or a removable. Most times they're removable. Examples are things like the tongue retraining device, which is this little white plastic thing. So what happens is the patient puts their tongue in this device under suction. It holds it out of the mouth, pulls that tongue away, opens up the airway in the back here. Just follow my little cursor right here. So the picture on the bottom right, all the way at the right end, is the tongue device kind of pulling that tongue away, and it opens up. It opens up the airway here, compared to when the tongue is falling back against the wall, the posterior wall of the pharynx. You put that tongue device in, it pulls your tongue away this way. Another thing that you can have is a mandibular advancement appliance. So you're putting up an appliance in the mouth, and that moves the lower jaw forward. Remember, the tongue and the lower jaw go hand in hand. You pull the jaw forward, the tongue comes forward and opens up the airway. So what are the indications for an ortho intervention? Patients with snoring or mild OSA who do not respond to treatment with behavioral measures. Patients with moderate to severe OSA who refuse treatment with CPAP. That machine is really hard to wear and sleep with. So some kids will not wear that machine. So they may tolerate the tongue device or the mandibular advancement device. And there are some patients that the ENT doctors do not think they're appropriate for tonsillectomy. Either they have underlying medical issues, or for whatever reason, they're usually the ENT guys have like a little checklist. So you have to not only have large tonsils, you have to have a positive sleep study test. You also have to have frequent ear infections or sore throats. So that's another question that I ask in my office when I see a patient with large tonsils. I say, does he have or she have frequent ear infections? Do they have ear tubes in? Do they have frequent sore throat? In addition to the snoring, the bedwetting, that usually all coming together would be a reason why the ENTs will want to take out the tonsils. So if for any reason they don't check off all the boxes, the ENT docs may say, you're not appropriate for a tonsillectomy or adenoidectomy, so we can't do this, but they're still having trouble sleeping. They're still having all the other features of OSA, but they have not been diagnosed with OSA, or they don't check all those boxes like I talked about. So you may use this orthodontic devices to help with that. And we already talked about the mechanism of action of the devices. So the advantage is there's a significant reduction in breathing pauses, improves airflow, reduces snoring, and it has a higher compliance levels compared to the CPAP. Disadvantages is there are reciprocal forces generated on the teeth and jaw by mandibular advancement splints, which may result in dry mouth, gum soreness, salivation, tooth pain, headaches, and TMJ problems. Complications of untreated OSA. So some parents may tell you, yeah, he snores, that's fine. It's not a big deal. In addition to comorbidities, as we mentioned earlier, untreated OSA may be combined with insulin resistance, especially kids that are overweight, and obesity, and may lead to heart disease and endocrinopathies in the future. So how do all these things kind of come together? How are they related? So when you have OSA, and at night you're not breathing at night, there's repeated periods of desaturation and reoxygenation. This will activate your chemoreceptors, especially usually it is the hypercarbia, meaning there's too much CO2 because you're not breathing, you're not performing adequate respiration. So the chemoreceptors in the brain are activated, and this would increase the activity of the sympathetic system and the renin-angiotensin-aldosterone system. This will cause increased generation of free radicals, pro-inflammatory cytokines. All of this will interfere with the action of the endocrine glands. The increased sympathetic response leads to high blood pressure, The endocrinopathies are associated with insulin resistance and dyslipidemia. Also, being bigger may be associated with insulin resistance, like I mentioned earlier. So all of this will precipitate what is called the metabolic syndrome. Metabolic syndrome is three things: increased blood pressure, insulin resistance, and dyslipidemia. So how is that important for us as pediatric dentists? If you perform sedation and surgical procedures in patients that have diagnosed OSA that have not been treated, please note that these patients may experience more perioperative and postoperative breathing complications. They're more likely to have laryngospasm. And what is laryngospasm? This is just the spasm of the vocal cords, temporarily making it difficult to breathe. It is an anesthetic emergency. If you have a patient with OSA or a patient that is bigger, there's a high chance that they could have laryngospasm if you are to sedate them or have them go to the operating room for general anesthesia. Once you note that this kid has laryngospasm, and the way you would know is there's going to be a high-pitched noise on inspiration. They're trying to breathe in, and you will hear things like, there is the vocal cords just shut close, such that when they try to breathe in, there's just no way the air is coming through. Once you know that there is laryngospasm, you need to remove any stimulus. So if you're working, stop working, apply your airway maneuvers to open the airway, and then administer anesthetic agents if that obstruction is not relieved. The airway manipulation is the jaw thrust, chin lift, and then you bag a mask, trying to break that laryngospasm. If that doesn't work, then you the anesthetic agents like propofol and muscle relaxants, or even lidocaine. What those do is they just render the muscles that close the vocal cords paralyzed, and things just fall open. It's important that if you do have a patient with laryngospasm, if you're sedating in office, to immediately activate 911 and try to do your jaw thrust, chin lift, and bag mask ventilation. You may most likely are not able to apply the anesthetic agents, so that's why you activate your 911 EMS response right away, so you can get those people in to help you break the laryngospasm. And it's really important to not manage patients with oral sedation in your office if you know that they are at a high risk for having laryngospasm, like the kids that we mentioned with diagnosed OSA, large tonsils, high Mallampati-Brodsky scores, patients that are obese, or patients that have conditions like Down syndrome. Those patients are best managed in the hospital. So what is the APD policy statement regarding OSA? APD recognizes that there may be consequences of untreated OSA that we talked about, and encourages healthcare professionals, including pediatric dentists, to screen patients for OSA, assess your tonsillopilar areas with your Brodsky and Mallampati evaluations, recognize that obesity may contribute to OSA, and refer to appropriate medical provider if you suspect OSA. Remember, we cannot diagnose OSA, but we can suspect it and call the physician's attention to it. Consider non-surgical intraoral appliances only after a complete ortho and craniofacial assessment of patient's growth and development has been done, and it should be as a part of a multidisciplinary approach. In conclusion, the effects of untreated sleep apnea on daily activities are multiple and includes excessive daytime sleepiness, impaired cognitive function, mood elevations, and personality changes. It is also related with reduction in quality of life, and there can be adverse changes on others, such as impaired relationships. It's important for pediatric dentists to be aware of the signs and symptoms and risk factors associated with pediatric OSA, and pediatric dentists should be comfortable making appropriate referrals and communicate with the orthodontist as well. It's also important to note that although this mentions pediatric dentist, as a general dentist um, that sees children, this is also appropriate for you. Here are the references. Thank you for listening. And if you have any questions, please feel free to email me. My email will be in the packet that you all received. Thank you for listening.